Hello, my name is Dr. Rocio Hurtado, and I'm the director of the Mycobacterial Center at Mass General. And today we're going to be talking about NTM. Great. So, over the next few minutes, we'll talk about some clinical syndromes. We'll understand the spectrum of disease and its complications, some novel strategies, as well as overall management strategies. So this is, of course, instills the fear in the hearts of many clinicians throughout the world related to the heterogeneity of NTM infections, greater than 190 species capable of causing disease in humans, the ever never-ending ubiquitous environmental reservoir, and the major difficulties in management related to their intracellular nature of this infection, the high rates of microbiologic recurrence, and the complex interplay between host and pathogens. The epidemiology is really interesting. These are present throughout the globe in water and soil. There are now, every year, there are additional species of NTM that are known to cause disease in humans. There are currently over 190. 30 account for the vast majority, and in fact, 3 to 4, depending on where you are in the globe, account for 95% of these infections, with Mycobacterium avium complex leading the pack with 85% of infections, followed by M. abscessus and M. kansasii. But these are very geographically restricted. So, for example, in parts of Europe, Malmoense is the second most common NTM in addition to MAC. There are about 200,000 cases of NTM in the US per year. This is in strike contrast to about 13,000 cases of tuberculosis in the US per year. And in the global arena, it is estimated that up to a third of non-cystic fibrosis related bronchiectasis patients have NTM as well, with post-TB bronchiectasis as a major risk factor. In Africa, almost 10% of mycobacterial cultures are actually NTM related, most likely in the context of post-TB bronchiectasis. In North America, as I mentioned, many more cases of NTM compared to TB. The rates are 10 to 20-fold higher in our population. There's also a wide spectrum of disease, ranging from colonization to invasive disease, primarily pulmonary, but also disseminated disease. And there's a complex dance between the host and the pathogen. The more immunosuppressed, the more some of these saprophytic, slow-growing NTMs that can disseminate, such as Haemophilus, Genevense, and Zolgai, rear their heads. And for pulmonary disease, there's a wide range in the pathogenicity, with Kansasii, Malmoense, and Zanopi leading the pack. Whereas other NTMs that are sometimes commonly isolated, especially in lab settings like Mycobacterium gordoniae, having much lower virulence and pathogenicity. And this is another depiction, and I include the citation here just to illustrate the wide range and the positive predictive value of true disease according to NTM species. I want to spend a minute on non-pulmonary clinical syndromes, just since many of you see patients outside of the pulmonary arena again. For localized extrapulmonary disease, this is traditionally primarily the rapid growers. This was a patient of mine who had nicked her hand while preparing fish. She was on low-dose prednisone and had a history of lymphoma, and she ended up having disseminated Mycobacterium coloni. There are also catheter device procedure associated NTMs. And then there's a widespread group of patients who are accessing elective cosmetic surgeries. And these are, the lipotourism industry that end up having rapid grower related NTM. Disseminated and multifocal NTM is associated with either individuals who have a genetic predisposition, which we'll briefly mention. A large group, and in fact, the largest group, are those with either iatrogenic related to immunosuppression or patients with acquired defects, and then heater cooler device contamination. And there was a large cardiac surgery heater cooler device outbreak that has now been it has is occurred about 12 years ago, which lasted several years, and we still periodically see cases. So, a brief word about disseminated disease and genetic defects. Many of these present in childhood, but I want to call your attention to the two forms of adult onset disseminated disease because you may actually see these in clinical practice. One form is the autointerferon gamma autoantibodies, and these are individuals who present in adulthood. Typically, their initial presentation is with an osteomyelitis or bone-related NTM disease. Initially, it was felt that this was primarily in individuals of Asian ancestry. We now know that that is not always the case, and in fact, recently we saw one in our hospital as well. Often, these patients have predisposition to additional pathogens, including Salmonella, Histoplasma, Penicillium. The other group are patients who have an acquired GATA2 deficiency, and these patients will often present in the context of either known hematologic malignancies like MDS or leukemias, or their presentation with NTM will precede the ultimate development of syndromes with a hematologic flare. So if you see someone who presents with disseminated disease, say a disseminated MAC, and has bone marrow abnormalities, you should think of the GATA2. And just a brief word about the heater cooler devices, since this was really a global outbreak. These are patients who were exposed to cardiac surgery, primarily cardiac bypass. And these infections presented with a very long latency, out to almost 7 years, high rates of disseminated disease. Many of them had involvement of their graft or original site of cardiac surgery, but they would have negative echoes. And in fact, the PET CTs would be positive. They're frequently misdiagnosed as sarcoidosis and then further immunosuppressed, leading to additional dissemination. So I just wanted to alert you to these. In the United States, since the advent of biologic agents, primarily the TNF alpha antagonists, the focus originally was on the risk of tuberculosis. However, we now have large-scale registries that show that local epidemiology is important. And I showed to you previously that NTM are a lot more prevalent in the United States than TB. And so it should be no surprise that, in fact, in several studies, the risk of NTM infections is actually higher than the risk of TB-related infections, just because we have more NTM here. And so I just share with you some of this data and some references for your perusal as well, with rheumatoid arthritis being one of the most common comorbidities and one of the most common indications for these. And in fact, these are patients who sometimes, even with mild disease or colonization, if they are about to start a biologic therapy, that may be a separate indication to treat. When we look at the pulmonary NTM patients, which will be the focus of this talk, we see different morphotypes and different phenotypes of patients. We'll see the classical, what we call Lady Windermere, women who tend to be of Caucasian origin. They tend to be of low BMI. About 40 to 60% will have scoliosis. Some will also have a pectus. And these are women who are otherwise immunocompetent. Another phenotype that we see are men, typically who have underlying COPD. There is a predisposition to cavitary disease, especially in those who have bullous emphysema. The other phenotype in men that's quite common is the gentleman who is a chronic aspirator, and those patients often have bilateral lower lobe disease as well. And then, of course, a large segment of patients who have bronchiectasis for other reasons, cystic fibrosis, pneumoconiosis, primary ciliary dyskinesia. One thing I want to highlight is that there have been now several series, including also from the Bronchiectasis Registry, which is a national registry, that have uncovered that the CFTR heterozygosity is quite prevalent, and depending on the series you look at, will vary between 10 to 50%. The difficulty is, of course, that many insurances do not cover testing for CFTR in this population, which tends to be older. However, if you are able to get testing and you uncover heterozygosity and it's with one of the mutations that is approved, say, for instance, a Delta 508, approved for the newer CF therapies, several of these patients actually are being treated with the targeted therapies. And we have a enlarging cohort in our center looking at the impact um, of targeted therapies in patients who have NTM and CFTR heterozygosity. I started my career in tuberculosis and drug-resistant TB. And so for the rest of the world, TB continues to be the major risk factor for bronchiectasis and therefore for NTM overseas. It's estimated that up to 86% of patients with TB post-completion of TB therapy will be left with scarring and bronchiectasis and numerous other complications outlined here. And this is just an example of the chronicity. And this is a cohort of mine with my colleagues in Ethiopia of the extensive lung damage that we see, in particular with chronic TB patients or patients with drug-resistant TB. Should be no surprise that several of these patients had NTM as well. We're going to shift gears and talk briefly about some of the radiographic findings of NTM. Traditionally, we have been told and taught that NTM is associated with thinner cavities, less surrounding parenchymal opacification, sorry for the typo, less distal bronchogenic spread. However, there are many, many exceptions, and many of us have seen, as have you, thick-walled cavities and basically very difficult to distinguish at times from TB and other intracellular infections. We do know that if bronchiectasis is present at the initial presentation, that NTM in the proper epidemiologic context. So, for instance, in North America, if you have someone, say, with cavitary disease and associated bronchiectasis who's smear positive in the U.S. without significant risk factors for tuberculosis, many of those will actually have NTM. Fibronodular disease occurs more commonly in women. I mentioned some of the morphotypes. Traditionally, the right middle lobe and lingula, most common, and pleural effusions are very, very uncommon with NTM. Bronchiectasis and adjacent multiple small nodules are the most predictive of NTM disease. These are just some representative samples that there's a wide presentation and expression of this disease. The top patient was a patient who presented with chest pain and had a pneumothorax and had underlying emphysema and had severe MAC, as well as co-infection with Aspergillus. This next patient had pulmonary alveolar proteinosis and presented with cavitary disease and massive hemoptysis. This next patient had a lipoid pneumonia and had Mycobacterium abscessus. And the final patient is a patient who had refractory MAC as well as a bronchopleural fistula and cavitary disease as well. So let's switch gears and talk a little bit about some diagnostics. We rely initially on sputum if the patient is productive, but many of our patients don't have wet bronchiectasis or are unable to produce. And so depending on the scenario, we may proceed with bronchoscopy and transbronchial biopsy. The utility of bronch in clinical practice, especially for patients who are unable to produce, is higher than for TB. But if patients are able to produce, I always encourage that you start with sputum. And sometimes what I see is patients start with bronch and their clinicians will not attempt to collect a sputum. And then I will see them and I will attempt to collect a sputum. And the reason I do that is not because it's going to add diagnostic certainty. It won't. If you already have a specimen in bronchoscopy that's growing, in the right clinical scenario, you'll probably meet ATS criteria. But the reason I try to collect sputums, even if the initial diagnosis was made on bronchoscopy, is that if I'm able to grow the organism in sputum, then I can use the sputum to monitor microbiologic response if patient needs therapy. Tissue diagnosis and is used in some scenarios as well. And there are some patients who will have isolated coin lesions, pet avid lesions, in whom we end up finding this incidentally, where malignancy was the major concern, and then lo and behold, a diagnosis of NTM is made as well. And then the other thing that I would point out is that what grows first, especially in patients who are productive or who undergo bronchoscopy, may not always be the pathogen. We've had patients who grow MAC and then later from endemic settings will ultimately grow TB as well. And then if you are suspecting in the right clinical scenario fastidious NTMs, the most common one relevant to the pulmonary space is Mycobacterium zenopi. Zenopi is a very fastidious slow grower. So if you have someone who is smear positive with a compatible syndrome and at the end of 2 months is not growing, that should really raise some red flags that your patient could have Mycobacterium zenopi. And so I would encourage you to request that the lab extend the incubation for an additional 2 to 3 months. If your host is at risk for disseminated disease, I would also encourage you to search for other sites, and or if they've had cardiac surgery and have had these heater cooler devices, blood isolators, urine for mycobacterial cultures may be necessary as well. There are many other mimickers above and beyond mycobacterial disease that can give similar presentations, other intracellular pathogens, dimorphic fungi, ANCA-associated disease, and even malignancy. So don't anchor. And some of these patients have more than one co-pathology as well. The newest and most exciting development in the field in the last year is the advent of the possibility of cell-free DNA rapid diagnostics. These are CRISPR-based assays, and these are done in serum. And OHSU in Oregon and the NIH Biobank group performed a study on different cohorts. One is a discovery cohort, one is a validation cohort, looking at MAC cell-free DNA in serum in patients with MAC pulmonary disease with a sensitivity that looks very promising, 97.6%, and a specificity of 97.6%. And the concentrations in those who underwent therapy amongst those who actually achieve culture conversion precipitously dropped. And so this is not available in clinical practice, but is generating a lot of buzz in the field. And I wanted you to be aware that perhaps in a few years we will have these rapid assays to help us, because traditionally culture-based assays can take several weeks for the growth of these organisms, and therefore real-time management, especially in patients in whom we're seeing them for the first time and they may have advanced disease and we want to get started, may not necessarily be possible with the current methodologies. All right. So let's talk a little bit about some of the co-pathologies and other things. So many of these patients have underlying bronchiectasis, so I don't have to remind this crowd to manage the co-pathologies. It's very important to be very aggressive about airway clearance, managing the obstruction and the complications. Esophageal dysmotility, incredibly common. Silent aspiration, GERD. I always tell my patients who say, oh, I don't have any GERD symptoms, therefore I don't have GERD, that when you look at large cohorts of patients, in particular with bronchiectasis and NTM, that 2/3 of patients will have esophageal dysmotility and will be periodically at risk for silent aspiration. Dysmotility and achalasia in particular tracks very nicely with the rapid growers. Semi-invasive fungi, mycotomas are not uncommon, especially in patients with underlying cavities that are chronic. Cavitary disease and steroid use are the most common associations. 5 to 10% of patients will have additional NTMs. The most common combination is MAC as primary and then Mycobacterium abscessus. And the chronic inflammation of these infections does increase the malignancy risk. The most common association is squamous cell cancers, but there's also a burgeoning literature with adenoCAs as well. This is a patient of mine who had longstanding bronchiectasis for about 30 years and had waxing and waning nodules, including an abnormality in the right middle lobe, who had a spiculated nodule in the right middle lobe at an area of an airway abnormality that she had had for 30 years. And she had many physicians across the country. And there was a little bit of a dissent in opinion whether to pursue this, because she had had a pre-existing abnormality. It turned out that, in fact, we were able to convince her that we were really concerned that this could still be a malignancy. And in fact, she had adeno-CA and is now surgically cured. But several other physicians had recommended against pursuing this, given her previous abnormality. This is a lady who was admitted to the MICU with respiratory failure and achalasia and had a lipoid pneumonia in the setting of M. abscessus. And this is a gentleman who presented with a pneumothorax and MAC and aspergillus. So let's switch gears. And in the last 20 minutes, we'll talk a little bit about what the current paradigm of NTM treatment is. The paradigm includes multiple drugs for a minimum of 12 months after culture conversion. This is riddled and plagued by a lot of complexities, ranging from the high rates of microbiologic recurrence, which can be as high as 50% in the case of MAC, many adverse effects, limited treatment options because there's a relatively short list of antimicrobials with intracellular activity. And the fact that many of these patients go through the revolving door. They become chronic, they relapse, many of them are reinfected, and the ongoing cycle of lung damage and inflammation continues. They then can, develop these mycotomas or semi-invasive aspergillus, hemoptysis, and many other complications. All right, so let's talk a little bit about antimycobacterial therapy and pulmonary NTM. So first, I want to highlight these are intracellular organisms that lead to lung damage, and therefore the cell serves as their cocoon, and they are occurring at areas of lung damage where drug delivery can sometimes be impaired. Even though there's overlap between some of the traditional drugs that we use for tuberculosis in the case of the slow growers, rifampin and ethambutol, I want to highlight that with the exception of Mycobacterium kansasii, which even though it is more pathogenic and can be more aggressive in patients, is actually easier to treat microbiologically. All other NTMs have MICs for these common TB drugs that are 100-fold higher. And so that's just to give you a sense that these are actually much, much harder to treat. We use as a surrogate marker for cure this concept of sustained culture conversion, which we traditionally use a 12-month metric if we can meet that. But there are situations where we may need to aim for longer. Those are patients who have extensive multibacillary disease, cavitary disease, retreatment patients, and certain patients with more aggressive and virulent NTMs. And I will highlight here Mycobacterium malmoense, which is more prevalent in Europe, which has a mortality rate of about 26%. And there are studies that show that longer treatment courses, closer to 2 years, have better outcomes compared to the traditional shorter, even though they're not short, treatment courses. And microbiologic recurrence for NTM, most of this data is from MAC, is about 50%. When we do molecular genotyping of the isolates compared to the original isolates that are banked in some research studies, or the University of Texas Tyler also often banks the specimens, and we compare the new isolate to the old isolate, up to 73% are actually new infections as opposed to relapse, i.e., the old strain failing to die. And 5 to 10% of patients will have dual NTM infection. The most common combination is M. abscessus, as previously mentioned. If you isolate M. abscessus once in a patient with MAC and you follow, you do serial sputum, you follow to see if there's evidence of radiographic or clinical progression, and patient does not meet any of those criteria, then you're not obliged to treat. All right. So in the pre-macrolide era, the cure rates were less than 50%. With the advent of clarithromycin, which was the prototype, and then subsequently azithromycin, the cure rates have increased significantly to 56 to 80%, depending on the series. And many of these series are a little bit heterogeneous in terms of their mix of fibronodular bronchiectasis, cavitary disease, a little lower, etc. No controlled trials. 20% of patients are unable to tolerate clarithromycin, so therefore azithromycin is the preferred, better tolerated, but it is a little more ototoxic. Thrice weekly regimens. I want to just emphasize here, beware of the pitfalls of thrice weekly regimens. We do not recommend them for patients who have cavitary disease, so do not use them in those patients. Patients who are retreatment, patients who have extensive disease, so multifocal extensive disease or high burden disease where they're persistently, very smear positive. Those patients were not included in the trials of thrice weekly. And I see this time and time again where patients are so worried about the side effects that clinicians will erroneously put them on these. The problem is that you can engender macrolide resistance and or poor treatment outcomes by misplacing patients with the appropriate regimens. In patients who have very extensive disease, primarily cavitary, multibacillary, don't be afraid to use IV amikacin up front. The first treatment course always results with the best outcome. Once you leave the first treatment course, your treatment success outcomes decrease to about 30% if you're lucky. This is in contrast to 50 to 80%. So you want to be aggressive. And then I will say, also highlighting for this crew that we really, really need to be careful about misusing drugs, misusing regimens. We really need to protect the macrolide because once you lose the macrolide and it becomes resistant, then the 1 year mortality is as high as 34%. So we don't do our patients any services if we don't do this right. And so the big risk factors for macrolide resistance, I would categorize them as actually three. Using macrolide monotherapy. So I always counsel my patients that if they're having flare-ups and they're going to be seen at urgent cares, especially those who are not yet on treatment or in between treatment, to not use macrolide monotherapy. And I also discourage the use of fluoroquinolones because that is a risk factor that tracks with the development of macrolide resistance. Ethambutol, including ethambutol in the treatment regimen, is actually a protective element. It decreases the risk of developing macrolide resistance. And many of you receive these susceptibility reports, and you'll see like high ethambutol MICs. We've never had good correlation between ethambutol MICs and activity, and therefore we try to include it unless there's a reason why we can't. And as I mentioned, if you do develop, and the third risk factor is being chronically on a non-suppressive regimen. So if you've got someone who's failing greater than 6 months and and you're not changing the regimen, and now it's 12 months and they're still failing, those are the patients who are much more likely to develop macrolide resistance because they have ongoing replication. All right. Let's talk about the refractory MAC. This is defined as patients who are culture positive 6 months into treatment. You want to evaluate the reasons for failure. Is there an issue with adherence? Are there subtherapeutic levels? Are there structural factors, i.e., patient has a dominant cavity and therefore poor penetration of the meds into the cavity? And or did you choose the wrong regimen? Did you have this patient on a 3 times per week? Molecular genotyping, if available. This is not widely available in clinical practice because many of the original isolates are tossed. There's only currently one lab, the University of Texas Tyler, that will do genotyping if they have the original isolate and then a new isolate. And that can help to determine if there's relapse versus reinfection. Oftentimes, there may not be necessarily amplification of resistance, and so some would argue that if it's not going to necessarily result in a management change, why pursue this? We have pursued it in several patients in our center, and most of the time the susceptibilities are quite similar, i.e., it doesn't really necessarily change our management, but many patients get incredibly discouraged when their NTM continues to grow, and it's sometimes helpful in terms of helping them sort of like move on and proceed with therapy to know that if there is a new infection, that's technically not like a failure per se of the regimen. You always want to ask the question, is there a surgical option? And for medical intensification, according to the ATS guidelines, initiation of inhaled liposomal amikacin, unless there's a severe contraindication, is indicated. Other strategies include the use of more drugs that we'll talk about in the next. We're going to talk a little bit now about rapid growers. There are three main species. Fortuitum and Coloni are very, very rare causes, almost very rare causes of pulmonary disease. So the major one is really Mycobacterium abscessus. It is the most hardy, drug-resistant NTM known to man. It's even resistant to bleach and certain disinfectants. It establishes a biofilm, and it has incredibly limited treatment options, and there's inducible macrolide resistance. If you are sending your isolates to commercial labs that do not screen for the inducible gene resistance, then you are going to be probably making some mistakes in your treatment regimen, assuming that many more patients have macrolide susceptibility than not. And in fact, most patients with Mycobacterium abscessus, subspecies abscessus, do not have are not macrolide susceptible or have inducible macrolide resistance as well. Very common pulmonary and esophageal copathology. So for M. abscessus, if there's no surgical option for many patients who have the gene, perennial culture conversion is actually deemed incredibly rare. The paradigm previously had been induction therapy with parenteral agents with length limited by toxicity followed by drug holiday. However, we now have some additional oral options such that we can often keep patients after the induction phase on an all oral regimen, depending on the susceptibility. I will say that you need to be very cautious about the reference labs that do susceptibility for these organisms because many of the commercial labs are not have quality control issues because these are very difficult assays to do. And so I would highly encourage those of you who have control over the contracts in your clinical labs to encourage sending these isolates to either the University of Texas Tyler or other national reference centers such as National Jewish. Most common agents are used up front or IV amikacin. Can also use one of the two beta-lactams, cefoxitin or imipenem. I will say imipenem in general is better tolerated. It has less hypersensitivity reactions compared to cefoxitin or tigecycline or nowadays omadacycline, linezolid in selected patients. If you include the macrolide, make sure that you you can count it as an active drug if your lab has screened for inducible gene resistance and inducible macrolide resistance via gene. Some patients, some clinicians will include it even if there is inducible macrolide resistance. And in that setting, we would include it for immunomodulation, but we wouldn't count it as an active drug. Other agents with potential activity include clofazimine, bedaquiline, omadacycline, which we briefly talked about, and Arava, as well as tadizolin. There have been periodically at times some shortages of amikacin, imipenem, and there's a lot of additional insurance-related barriers for approval of certain medications. And then clofazimine is obtained through either multi-patient IND, if you are linked to a center that has a multi-patient IND, or you can petition it single use to the FDA directly. For Mycobacterium abscessus subspecies massiliense, this subspecies does not have inducible macrolide resistance, and so the treatment outcomes are actually much more favorable because the macrolides have reliable activity as well. All right, the ATS guidelines, just to quickly bring everybody up to speed, they're now about 5 years old for pulmonary MAC. The change was that azithro is now the preferred macrolide, and to be aware of what are the indications of thrice weekly regimens that we discussed, to use IV amikacin, preferably if there is cavitary disease, and then if the patient is failing, which is defined as culture positive 6 months or longer, to intensify with liposomal inhaled amikacin. For pulmonary M. abscessus, to screen for inducible gene, as mentioned, and therapy to be guided by susceptibility testing. You want to include at least 3 active drugs, in some cases with extensive disease 4 as well. For M. kansasii, rifampin makes a huge difference. There's a big drop off in clinical outcomes if you cannot include rifampin. And so I encourage you by all means to try to include rifampin. Many of our patients are older, they're on anticoagulation. And so if you need to switch off to Lovenox or even warfarin, which is hard to manage but not impossible to manage, you just need to be in close communication with the anticoagulation service and explain to the patients that their warfarin dose will increase from 2 to 5 milligrams to 20 to 25 in some cases so that they don't get alarmed. I would encourage you to do so. A few core principles, just because the treatment is really, really tough for these patients. And so the first thing I want to say is that it's actually very important to manage expectations up front. Many patients are thinking of a binary model of infection here, yes or no. And many of these patients actually become chronic, have periods of drug holidays, get reinfected. And so really trying to spend that initial visit to let them know what the roadmap is going to be is super important. Um, let them also express what their patient values and their goals and expectations are. If you have someone who has bona fide pulmonary MAC, but who's in their 90s and is doesn't have a good indication for treatment, the risk benefit doesn't currently favor for many of those patients. But there are other patients who for whom even at a younger age, we now know that we're in fact undertreating many of these patients. So be clear. Many of patients try to navigate and say, I really, really can't tolerate the thought of having like ethambutol with the eye toxicity lingering over my head. And you have to have very frank discussions that, for example, not including this agent just because of fear will potentially increase their risk will impact efficacy, increase their risk of macrolide resistance, etc. Not all adverse effects are created equal. You'll have to know when to push on, when to pause, and when to quit. So if you have a rifampin related platelet count of 10, that is something that you obviously cannot push on, or a generalized rash that has concerning features. You can't, really like include that in the regimen. And then I will just say that frequent support and communication are key. Maintaining a strong relationship with your patients is often a good predictor to getting them to the finish line and supporting them through this very, very long road. A few strategies. Staggered introduction. I never start my meds all at once. And reintroduction if patients are struggling. Nighttime dosing, in particular for the rifamycins like rifampin, because rifampin typically peaks at 2 hours. And so by the time they wake up, some patients are able to tolerate it better because the drug levels during the day are lower. Do not split dosing. I see a lot of clinicians doing that, where their ethambutol is split to 400 twice a day. That affects your efficacy. Most of the MAC drugs, for example, are concentration dependent killers, which means if you split, then you don't have the time above the MIC, and then your patient's really not getting credit for that. The exception is with omadacycline, where patients who can't tolerate the full dose, because the MICs are so low, we can sometimes split. If you use tigecycline, we often start low and go slow as well, and the target dose is lower. The target dose of tigecycline is only 50 milligrams Q24. Always be sure to tell your patients to maintain their hydration status because many of them don't eat or drink as much. In select scenarios, therapeutic drug monitoring might be helpful. And a drug holiday in some scenarios where patients are just doing poorly and need a reset can actually be incredibly helpful to then strategize what your next step will be. Just going to briefly go over some new medicines. So amikacin inhaled liposomal, not so new anymore, around and FDA approved since 2018 on the basis of the CONVERT trial, where continuation of the optimal background, these were patients who were culture positive at 6 months and beyond, resulted in a culture conversion rate of 8.9% versus almost 30% for those patients who had their regimen plus inhaled amikacin. Data from the 12-month treatment course, no new safety signals, and the culture conversion rates were maintained. The ARISE data, which was presented last year at ATS, compared the efficacy of inhaled liposomal with added to a background regimen up front of azithromycin and ethambutol. So these are treatment naive patients as opposed to retreatment patients, which was a different population that was originally studied in the CONVERT. And by month 7, culture conversion rates were as high as 70, almost 79% in the inhaled liposomal, compared to 47.1% in the comparator arm. In clinical practice, however, I will say in general, this can sometimes be challenging for patients to tolerate. The most common side effects include, I will say, first, dysphonia, so hoarseness, incredibly common. And in some situations, we have to stop the drug and let them sort of let their voice return and then reinitiate 3 times per week and then slowly re-escalate to target. Cough, bronchospasm, and 3% of up to 1% of the time, a hypersensitivity pneumonitis, and that is a no-go situation. This is a systematic review that outlines according to study the rates of ototoxicity, GI symptoms, renal failure, etc. All of these things by study that I encourage you to read as well. Bedaquiline original series was of 10 patients published in Chest 10 years ago. We're in the process of publishing our cohort of 34 patients treated with bedaquiline. And I include here some insights into bedaquiline resistance. I will say in general, while I do think it is a promising drug and it has helped several of our patients in our cohort, it's becoming increasingly difficult in getting insurances to cover bedaquiline. It's about a $30,000 price tag for a 6-month course. And so I think the logistical barriers are real. Clofazimine, which has been used in our field of multi-drug resistant TB for over 25 years and has been one of the key elements in some of the cardinal trials, including the STREAM trial that was conducted by our group, that heralded the new short course regimens for MDR-TB. But for pulmonary NTM, several published cohorts listed here with culture conversion rates in the 67% range. However, some of them with higher rates of relapse, others with 43% clinical response. There is in vitro synergy when you're able to use clofazimine and amikacin, as well as clofazimine and tigecycline for M. abscessus, and emerging synergy data with bedaquiline, but there's also cross-resistance with bedaquiline as well. A lot of interest in vitro with regards to the novel beta-lactams and inhibitors for NTM. I will say there is one research lab by Dr. Bonomo in the Midwest that will actually do synergy curves for patients in whom we've periodically sent isolates. These are not available for clinical practice, and they'll do the kill curves. And then if you want to employ these strategies, and typically they're employed if you're using them as a Hail Mary, for lack of a better term, in patients with either disseminated disease or refractory disease who may not be eligible for other therapies. The NIH periodically uses meropenem ciftereline. We've also used that agent as well, or imipenem ciftereline as well. And then I will say that there are several other active clinical trials. We talked about the ARISE trial for inhaled amikacin up front. There's a trial enrolling, including at our Center for Inhaled Clofazimine, and there is a trial looking at omadacycline for pulmonary M. abscessus. I've provided the link here. This is the current, most recent link of all of the studies. Most of these are not treatment studies, but at your leisure, have a look at these. Any other potential options for those who have localized disease, very drug-resistant disease, macrolide-resistant disease? Always ask the question, is your patient eligible for surgery? Surgery can be game-changing in the treatment of these patients. We typically do a lead-in, make sure that they are optimized prior to surgery, and then we do a post-operative tail, typically in the 6 to 12-month range. But surgery can be curative for many patients, and for those who are carefully screened and have adequate nutritional reserve, adequate pulmonary reserve, don't have advanced pulmonary hypertension, it has actually been a game changer. And then mycobacteriophages. This drummed up a lot of excitement a few years ago when a young girl with cystic fibrosis, who was a transplant candidate with disseminated M. abscessus, accessed this therapy and had a three-phase cocktail, prolonged IV therapy with improvement in her disseminated disease, however, died at 44 months. There have now been over 20 patients treated. This is primarily for M. abscessus with favorable outcome in 11 out of 20. 8 out of 20 developed neutralizing antibodies. There is a group that is now going to be starting a study for compassionate use of phage. This is not, unfortunately, I don't think going to be a blockbuster. There's a lot of regulatory related issues. There's also the phage has to be very specific to the patient strain. So this is something where you have to first screen a cDNA library to see if you have a phage match. Ideally, you would have more than one phage match. The original had a three-phage match. Many patients only have a one or two phage match, and so long-term consequence of only having one or two. Thus far, we haven't seen signals in resistance, but there is that theoretical concern. So microbiologic recurrence is high. Optimize their airway clearance. Always ask if there's a surgical option, and always look to see what other salvage agents you can use, and expectation management as well as support during therapy. So with this, I will close and I will see you all at the Q&A. Thank you very much.